So, systemic lupus erythematosus. We have hypersensitivity reactions that are reactions that are against the self and damage the self. These reactions are four types, also five, let's say. It's type 1, it's immediate, IgE mediated, and the typical clinical manifestations are anaphylaxis, angioedema, or urticaria. The type 2, which is cytotoxic, is IgM, IgG, and complement phagocytosis mediated. We have manifestations of cytopenia and nephritis. In type 3, which is immune complex related, we have an effect as effector mechanisms IgM, IgG, complement, and precipitins. It's involved in serum sickness and vasculitis. Type 4, the one that is called delayed, is mediated by T lymphocytes and is involved in contact dermatitis, for example. And then there are others, idiopathic. The effector mechanism varies, and we have as a manifestation a non-specific rash. So, the delayed one is delayed because it is mediated by T cells that need antigen presentation to be activated, like also in the tuberculin reaction. If you inject tuberculin subcutaneously, you see the reaction after 2-3 days. And this mechanism is also found in allergy, mostly the one of the skin. These mechanisms are also found in SLE, since the damage caused by the virus autoantibodies exploits one of them. In this scheme, you see the role of the antibodies, you see the mechanism of damage. IgA leads to mast cell activation, IgG, FCR cells like phagocytes and NK cells. In type 3 IgG, we have FCR cells and complement, Th1 macrophage activation, Th2 eosinophil activation, CTL cytotoxicity. Anyway, IgG are damaging the tissue because they have the receptor on mast cells. The mast cells recognize the IgG and when bound to the antigen and respond with release of histamine, for instance. IgE is recognized by mast cells, causing the release of their granules, mainly histamine. Step 2. If you have an an immunoglobulin bound to platelets, this mediates the deposition of complement and a more effective phagocytosis by macrophages and hemolytic destruction. In type 3, we have an immune complex deposition and a complement fixation. Type 4, which is mediated by Th1 and Th2 and cytotoxic T cells that are activated in the lymph nodes and then go back to the periphery. Systemic lupus erythematosus, it's a chronic relapsing inflammatory and often febrile multisystemic disorder of the connective tissue, characterized principally by involvement of the skin, joints, kidneys, and serosal membranes, and to some extent the CNS. It's of unknown etiology, but it is thought to represent a failure of the regulatory mechanisms of the immune system. By now, we only have hints about the pathophysiological events underlying some clinical manifestations. The disease comprises a wide range of system dysfunctions, autoantibodies, and systemic inflammation. Epidemiology, we have a prevalence of 1550 over 10,000, over 100,000, age between 15 and 50, male to female ratio 1 to 9, so usually young female patients. You notice that the onset is between puberty and menopause, and in fact there is a correlation with estrogen hormone. Risk factors are genetic susceptibility, ethnicity, family history plays a role, as well as individual genes. The concordance in homozygous twins is 40%. Genetic susceptibility in autoimmune diseases is usually not linked to one single specific immune disease, but is usually broader. Therefore, you may also have a familiar genetic susceptibility towards more autoimmune diseases. Sometimes this predisposition is also towards allergies. You have also hormones like estrogen and prolactin. These are particularly evident during flares of the disease. In fact, SLE is frequently a relapsing, remitting phenotype. After pregnancy, especially, we have an increase in flares, and this has been linked to prolactin. What overall seems to be altered by hormones is the B cell selection. Clearly, women in this age are more prone to men to have an altered selection and develop immunity, SLE in particular. Environmental factors are linked to the induction of flare in affected patients, but not in the etiology. So they're not involved in the etiology, but in the induction of the flares. We have UVA B exposure, so the damaged DNA. UV light triggers apoptotic cell death of keratinocytes, and this makes antigens available to antibodies that need anyway to be already present in the organism. We have then infectious agents like viruses, polyclonal activation of B cells. We have drugs like isoniazid alpha-methyl-dopa and smoke. Several genetic polymorphisms have been identified, more than 300, mainly in non-coding regions. Low risk for single polymorphism, development of the disease for the combination of many polymorphisms. The current paradigm states that the combined presence of different predisposing alleles imbalances the immune system toward a behavior that promotes the reaction against the self beyond the limits of tolerance. The female sex hormones further aggravate this imbalance, thereby pushing the immune system toward autoimmunity. The tolerance would definitely be broken at a certain point due to an environmental factor able to activate the immune response. For sure, at the end, we have an increase in the number of autoimmune B cells that get activated and produce auto-IgGs. In SLE, we have auto-IgGs against hundreds of autoantigens, even if the one we measure in clinic are just few. In SLE, there are also defects in the cells of the innate immune system. It has been noticed that relatives of patients have defect in the clearance of cellular remnants, apoptotic cells, nets, therefore all those parts of the self that are that should be cleared once produced. Both patients and relatives are slower in this process, and this could be at the base of the increased production of auto-IgGs, auto-antibodies. In fact, apoptotic cell antigens, if not cleared immediately, acquire characteristics increasing their ability to activate the immune system, and they become more immunogenic. They're present in an environment that is pro-inflammatory and pro-autoimmune. When there is an inflammation, bacterial infection for instance, usually all markers of inflammation rise simultaneously in a healthy patient. In autoimmune patients, instead, you often have selective rise only in fibrinogen and ESR, while CRP and other inflammatory markers, like pentraxins, are very low. What is important to remember is that a characteristic of pentraxins, CPR is one of them, is that they bind to cellular remnants and they quench their immunogenicity. Lack of increase of pentraxins in autoimmune patients during inflammation can be associated with an increased immunogenicity of cell remnants and increased autoimmunity, as explained above. Pathogenesis. Autoantigens are presented in a context of danger. Then dendritic cells are activated and mature. We have genetic predisposition and pro-inflammatory environment. Then we have T cell stimulation, B cell stimulation, which leads to an increase in antibodies. Then antibody-mediated cell cytotoxicity, which is type 2 reaction. Immunocomplexes deposition, type 3 reaction, and then further dendritic cell activation. The antibodies are antinuclear antibodies, ANA, revealed by immunofluorescence. Antibody anti-ENA, extractable nuclear antigen, the antigens contained in the nucleus. The patient in most of the cases is also NAA positive. We extract them and we divide them in the different antigens. Then we analyze them by ELISA. We have anti-spliceosome, anti-SM, which is a component of the spliceosome, highly specific for SLE but not highly sensitive. If the test is positive, the possibility that the patient has SLE is very high, but not vice versa. Then we have anti-RNP, which is a ribonucleoprotein component of the spliceosome. It identifies patients with SLE plus MCTD, mixed connective tissue disease, systemic sclerosis, and others. Anti-Rho, that is SSA, cytoplasm, typical of patients with both SLE and Sjogren, but they may be positive also in Sjogren alone. We have anti-La, SSB, DNA, which is involved in the DNA transcription, typical of patients with both SLE and Sjogren, but they may be positive also in Sjogren alone. Anti-PCNA, which is involved in DNA replication, which is highly specific for SLE, very rare, but is asked together with the others when testing anti-ENA. Anti-DNA antibodies like ssDNA, dsDNA, they are associated with renal involvement in SLE. Their titer correlates with the severity of the renal problems. For this reason, they are used to monitor kidney in these patients. We have antibodies, anti-membrane receptors, so anti-beta-2 glycoprotein 1, that are anticardiolipin and antiphospholipid. We have anti-red blood cells and antiplatelets, which are responsible for thrombocytopenia and anemia. The ACR criteria of 1970 are useful for the diagnosis when you want to enroll a group of patients homogeneous enough to hope to see some results if you want to test a new drug. The proper diagnosis is clinical and is based on these major presentations plus others, minor ones that anyway may have an important role in the single patient. Do not use this criteria as a checklist to diagnose patients with SLE. Diagnosis leads to equal or more than 4 criteria over 11. We need a malar rash, discoid rash, photosensibility, oral ulcers, which are also found in the Sjogren syndrome, Behçet disease, and Crohn's disease, that are considered as a differential diagnosis. We need also arthritis, serotitis, such as pleuritis and pericarditis. We have kidney manifestations, so proteinuria under 0.5 over 24 hours and cellular casts. We need also neurological manifestations, seizures, psychosis, and cerebrovascular events. We need hematological manifestations like leukopenia or lymphopenia, hemolytic anemia, COMS positive, and thrombocytopenia. We need also autoantibodies. The only ones used for diagnosis are anti-DNA, anti-SMIT, antiphospholipid, and LAC. We have also antinuclear antibodies, proteinuria more than 0.5 over 24 hours, and cellular casts. The clinical manifestations of SLE are systemic inflammation. So, fever is found in 40% of patients at least at the onset before any treatment. You have to exclude an infection as possible cause of fever. You have also fatigue, anorexia, weight loss. All clinical features of an inflamed patient can be present. Very often also lymphadenopathy in many different sites is present, 60%. You have to sample some of these lymph nodes to exclude lymphoma as differential diagnosis. These lymph nodes are filled with inflammatory cells and macrophages that do not clear cellular remnants. In fact, in vivo, you usually do not see apoptotic cells that are cleared immediately, while in this case you are able to see them. And this is connected to an increased size of lymph nodes. Then, on the mucocutaneous side, we can have acute lesions during the acute phase or chronic lesions. In the acute lesions can be the malar rash, which is the butterfly rash, here on the right, present in 50% of patients. It's a fixed, flat erythema that extends from cheek to cheek, across the nose, sparing the nasolabial folds. It is often associated with itching or pain. At that histological examination, we appreciate the presence of immunocomplexes responsible for the inflammation. So here we have sparing of the nasolabial folds. Photosensibility is very frequent, 70% of patients, characterized by the occurrence of erythematus, sometimes maculopapular lesions, after exposure to sunlight in quantities not sufficient to induce sunburn, so very short time. It's prominent during the acute phase and much less evident during remission. We have a chronic lesions such as a discoid rash. You can see it on the right. It's the only chronic lesion that is considered as criterion. It is present in 15% of patients. The typical location is the sun-exposed areas. It presents with small, well-demarcated plaques with an atrophic, hypopigmented, and airless central area. On histological examination, we see hyperkeratosis, edema, and extensive infiltration by monocytes. The latter is typical of chronic inflammation. No immune complexes are present. We have then a vasculitic inflammation, which is present here on the left, but it's not a criteria, but is typical. It's present on the hands, fingers, arms, legs. They typically present with petechia. We have oral ulcers, which are found in 40% of patients, generally not very painful. We have other mucocutaneous lesions then, such as subcutaneous nodules, alopecia, vasculitic purpura, Raynaud's phenomenon, oral nasopharyngeal ulcers, xerodalmia and xerostomia, T secondary Sjogren syndrome. The musculoskeletal side we have arthralgia and muscle pain are common, 95% of cases. Arthritis is the criterion. We have non-erosive arthritis in 60% of cases, and Jacques arthropathy in 15% of cases are the most common ones. Then we have other less common arthritic manifestations that may create some confusion with rheumatoid arthritis. We have symmetrical erosive polyarthritis simil array and minimally erosive arthritis. Muscular manifestations such as myositis and fibromyalgia could be another presentation. We also have an increased incidence of ischemic bone necrosis linked to the therapy with corticosteroids. Arthritis can be non-erosive arthritis in 60% of patients. It's systemic, so the involvement is symmetrical, mostly affecting hands, proximal interphalangeal joints. Differently from rheumatoid arthritis, the synovium doesn't invade the bone. It usually involves two or more peripheral joints. It's characterized by swelling, stiffness, and joint tear fusion, but no redness. We can have a similar rheumatoid arthritis. We have articular symptoms and findings of rheumatoid arthritis, frequently positive for rheumatoid factor. Clinical picture of SLE is relatively mild. We can have also minimally erosive arthritis, which is a dominant clinical picture of SLE, synovitis. We can have Jacques arthropathy in 15% of cases, which is a chronic inflammation of the joint capsule and tendon, resulting in joint instability, at the beginning reversible, then permanent. To try to control the disease, you have to control inflammation that is typical of the early phases. Deformities may let you think about long-lasting rheumatoid arthritis, but there is no erosion on the X-ray. In the early stages, appearance of articular abnormalities, subluxations, without inflammation. Most frequently on the hands. Inspection findings similar to rheumatoid arthritis and zone blast. Finger swollen, neck or boutonniere. We have then ischemic necrosis of the bone. It's an acute complication of high-dose steroid therapy. The risk factors are the following: young age, previous arthritis, and therapy, use of corticosteroids and cytotoxic therapies. Fourth manifestation is lupus nephritis, which is the kidney manifestation, the most well-known complication and also the leading cause of morbidity and mortality in SLE is lupus nephritis. It affects 50% of SLE patients. The rate of survival changed in the last years thanks to corticosteroids and then thanks to cytotoxic drugs. Cyclophosphamide is still nowadays first-line therapy. In 2007, the survival was 80% after 15 years. Nowadays, we are close to 90%. Despite therapy, 10% of patients develop renal failure, and undergo dialysis or kidney transplantation is another option. Please consider that SLE is not a static disease. There are periods of remission, periods of flares, and anytime we can have the appearance of some new signs and symptoms and disappearance of others. It's very dynamic. Therefore, when we say that 50% of patients have kidney manifestation, we mean that 50% of patients will have kidney problems at least once during the course of the disease throughout their lives, and not at any moment. Pathogenesis, we have kidney involvement is mediated, in most of the cases, by immune complexes deposition, either coming from the filtered blood or directly forming in the kidney, complement activation and inflammation glomerulonephritis. Other possible causes of kidney involvement could be due to thrombotic microangiopathy and atherosclerosis that can be found in SLE. But in general, the most common picture is the first one. We can do a biopsy or aggressive immunosuppressive treatment. And then aggressive immunosuppressive treatment. The clinical manifestations are in SLE, you can have either a nephrotic or a nephritic syndrome, even though the most common manifestation is proteinuria, so nephrotic syndrome. Proteinuria is more than 500 milligrams per over 24 hours. We have an active urinary sediment with hematuria pyuria characterized by cellular casts. They are sediments that you can see if you look at urinary sediments under the microscope. Fresh sediment analysis is a type of analysis that you have to ask for when performing urinary analysis. What you see are these casts made by cells, red blood cells, remnants of cells that are kept together by acute phase reactants and molecules of inflammatory processes generated inside the kidney. These casts have the shape and size of the urinary tracts, and they do not dissolve in the urine thanks to the inflammatory molecules. They are a sign of an acute inflammation occurring in the kidney. It's a hallmark of the disease. You have hypertension, which is a hallmark of nephritic syndrome. With time, you can have an increase of serum creatinine and finally leading to chronic renal failure. When you have active lupus nephritis, you have both proteinuria and hypertension. The involvement of the kidney is something that leads us to treat the patient with an aggressive immunosuppressive treatment. We have cyclophosphamide at the beginning, then high-dose corticosteroids. The new treatments for lupus nephritis are based on anti-CD20 antibody that are supposed to kill the activated antibody and try to reduce the titer of anti-DNA antibodies. When you have lupus nephritis in the therapy, you have two phases. The first phase aims at the induction of remission, cyclophosphamide and high-dose corticosteroids. Anti-CD20 mAbs are still under study. Then, once you obtain remission, you need to maintain it for at least 2 years before trying to withdraw the drugs. Zatiraprine, methotrexate, immunosuppressant in general, but all less toxic than cyclophosphamide. Lupus patients that reaches dialysis enters in remission. Why? During dialysis, you take out many constituents of the blood, not cells. Small molecules are removed, cytokines, chemokines, and others, and these are possibly connected with the sustained inflammation present in these patients. Remission by dialysis takes about 1 year, therefore it cannot be used as therapy in other patients apart from the ones in renal failure. Some autoimmune diseases in young patients not performing well, we can perform plasmapheresis or even a plasma exchange, always in combination with the other therapies. Some benefits may be obtained. Still, at the end of the story, the mechanism at the base of this improvement is not that clear. Biopsy has to be performed in these patients because according to the histological picture, we're able to give a prognosis. We have 6 classes of kidney failure of kidney manifestations in lupus nephritis. We have class 1, which is minimal mesangial with an excellent prognosis. Type 2, mesangial proliferative with a good prognosis. Type 3, focal with a moderate prognosis. Type 4, diffuse with a moderate poor prognosis. Type 5, membranous with a moderate prognosis. And 6, advanced sclerosing with a poor prognosis. Serositis is another manifestation. Very common, pleural involvement. Pleuritis occurs in 50% of patients. You have pleural pain augmented by breath, which is the most frequent presentation. Pleural friction rub on auscultation, pleural effusion on X-ray, typically modest and bilateral, but sometimes can be massive. Then we have pericardial disease, which is fibrinous pericarditis in 30% of patients. It can be pericardial pain augmented by the position, patient leaning forward. Pericardial effusion on ultrasound. You have pericardial friction rub on auscultation. Diffuse ischemic like ECG abnormalities, possible cardiac tamponade. These two conditions are also commonly found in SLE patients that are asymptomatic. It's not rare. Cardiac manifestations are, apart from the pericarditis, we have other problems, such as myocarditis in 10% of patients associated with anti-Ro antibodies, SSA. It can be diagnosed especially in presence of arrhythmias. In endocarditis, 60% of patients, so rather common, characterized by thickening of the mitral valve. Typical of lupus are also the vegetations, always on the mitral valve, called verrucous endocarditis of Liebman-Sachs. Myocardial ischemia can also develop since we have an accelerated coronary atherosclerosis in lupus. Remember that the first cause of death in SLE patients nowadays is for cardiovascular problems. For this reason, the indication in the last years have been to reduce the burden of steroids that were widely used before. What instead is clear now is that the increased incidence of atherosclerotic events is not linked to the use of steroids in these patients, but mostly with the disease itself. The trend of SLE patients is opposite to the one expected in women of their age. Between 15 and 50 years, women are protected by hormones from cardiovascular events. In a recent study, LDL and other lipoproteins turned out to contain a lot of acute phase reactants in their structure, and this is thought to increase the rate of deposition and making them more inflammatory. Pulmonary manifestations, then, can be pleuritis and pleural effusion together with lupus pneumonia. Non-infectious are very common and characteristic, and you have to remember them. Pulmonary hemorrhage instead is rare but often fatal. Pulmonary hypertension may also be present, but anyway it's more typical of systemic sclerosis. Overall, you have a restriction of lung function due to pleuritis, myositis, and phrenic nerve paralysis. You have also neurologic and psychiatric manifestations, which are very common, affecting overall 60% of patients. The underlying mechanism of damage is not clear since autoantibodies theoretically should not reach the CNS. Anyway, cognitive functions are typically impaired, and especially memory. Ischemic events in SLE are often linked to vasculitis or antiphospholipid syndrome, which is typical of this patient. As usual, you need to exclude other causes for the diagnosis. In particular, consider corticosteroid-related psychosis. You can have the central nervous system, seizures, stroke, cognitive dysfunction, acute confusional states, motor disorders, mood disorders, anxiety, psychosis, headache, myelopathy, demyelinating diseases, aseptic meningitis. The peripheral nervous system, less frequently, we have cranial nerve involvement, polyneuropathy or mononeuropathy, single or multiple, Guillain-Barré syndrome, myasthenia gravis, and dysautonomias. Hematologic manifestations are all series can be involved. For hemolytic anemia with reticulocytosis due to antibodies against red blood cells and inflammation, leukopenia less than 4,000 over square cubic millimeter, also common, especially lymphopenia, that is less than 1,500 per cubic millimeters. It's due to a defect in the bone marrow. Infiltration impairs production of these cells. You have thrombocytopenia, which is less than 100,000 per cubic milliliter can be due to autoantibodies against platelets, but also to antiphospholipid antibodies because they bind to the phosphatidylserine that is exposed by activated platelets. We have antiphospholipid antibody syndrome, where we have an increased incidence of hematologic malignancies. In antiphospholipid antibody syndrome, it's the superimposition of two syndromes, thromboembolic and obstetrical. You can have patients that have both or either one of the two syndromes. The two syndromes are both caused by antiphospholipid antibodies that are criteria for diagnosis of lupus, and these autoantibodies can be present in lupus patients or in patients that have no other systemic autoimmune disease, so isolated. It can be primary, so isolated, 5% of the population, or secondary, which is associated with a different systemic autoimmune disease. 50% of cases are in SLE patients. The presence of autoantibodies is associated with arterial or venous thrombosis, pregnancy complication, so we have abortion risk, abortion in more than 10-15% of cases at less than 10 weeks of gestational age. We have livedo reticularis. The pathogenesis. The autoantibodies actually do not recognize phospholipids, but their antigen is beta-2-glycoprotein 1, which is a plasma cofactor. It's a serum protein that binds anionic phospholipids that usually are inside the cell on the inner membrane and are exposed in case of apoptosis, nets activated platelets, such as phosphatidylserine, and once bound to them it changes conformation, showing the epitope, domain 1, recognized by the autoantibodies. Binding of autoantibodies interferes with clotting system, making clotting more frequent and interferes in placenta formation as well. Beta-2 glycoprotein 1 is not the only antigen. There are also prothrombinase protein C and protein S. Clearly, the antibodies recognizing the latter are different from the ones recognizing the former. In fact, we are dealing with a family of autoantibodies rather than with a single one. What these have in common is the clinical presentation. In the placenta, the mechanism of action is very complicated because they can interfere with multiple steps of the placenta formation. This is because both syncytiotrophoblasts and the extravillous cytotrophoblast expose phosphatidylserine, becoming substrates for the binding of cofactors and antibodies. In the early phases, they increase the risk of abortion, while in the late phases, they increase the rate of complications, so eclampsia, fetal death, and others. The following are the criteria for diagnosis. So clinical criteria are vascular thrombosis, so one or more episodes of arterial, venous, or small vessel thrombosis in any tissue or organ. Then morbidity in pregnancy, one or more unexplained deaths of a morphologically normal fetus at or beyond the 10th week of gestation, one or more premature births of a morphologically normal neonate prior to the 34th week of gestation secondary to eclampsia or severe preeclampsia or recognized features of placental insufficiency, then 3 or more unexplained consecutive spontaneous miscarriages before the 10th week of gestation. Laboratory criteria must be present on 2 or more occasions at least 12 weeks apart, are lupus anticoagulant present, anticradiolipin antibody, can be medium or high titer of IgG or IgM isotype, and anti-beta-2 glycoprotein, medium or high titer of IgG or IgM isotype. For diagnosis, we need to have one clinical finding and one positive laboratory test. Lupus, like anticoagulant, in vitro works as an anticoagulant, while in vivo causes thrombosis. It's a function of antiphospholipid antibodies found in serum. It's a test, an ability of serum of patients to elongate the PTT of healthy serum. By performing this very simple test, you can tell if a lupus patient has antiphospholipid antibodies or not. If a SLE patient has antiphospholipid syndrome, lupus involvement of some organs, thrombocytopenia, CNS involvement, is more frequent than in patients that have SLE but no antiphospholipid syndrome. This is livedo reticularis. It's a vasodilation due to presence of antibodies. We have activated endothelial cells which lead to endothelial cell activation, and endothelial cell activation is a procoagulant thrombotic event. Activated platelets lead to initiation of coagulation thrombosis and consequent thrombocytopenia. In the placenta, we have complement-mediated inflammatory damage. The immunological abnormalities are anti-DNA and anti-ENA antibodies, antiphospholipid antibodies, so antiphospholipid and ACA, anti-beta-2-glycoprotein IgG and or IgM, lupus-like anticoagulant positivity, serology test for syphilis false positivity, and must be for at least 6 months, and if treponema pallidum immobilization and fluorescent treponemal antibody tests are negative. So, lupus-like anticoagulant owes its name to the ability to transfer the elongation of the PTT, partial thromboplastin time, to the plasma of normal subjects, unlike the elongation due to defects in coagulation factors that is not transmitted to normal sera, but rather is corrected by the addition of normal serum. Laboratory tests are inflammatory markers, ESR and anemia, but CRP is often normal and leukopenia is present, and this is something uncommon in inflammation. We have consumption of complement due to antibodies or immune complexes deposition, especially decrease in C3 and C4. It's an indirect marker of the rate of deposition of antibodies. We have autoantibodies positivity, NAA anti-ENA antiphospholipids, detected by immunofluorescence or ELISA liver function test. So we have SLE-related hepatitis and drug-related toxicity, and renal function test if we have nephritis. Mechanisms of damage in SLE. F type 2, which is a hematological manifestation. That is, we have a recognition of the Fc receptor of cytotoxic cells, antibody-mediated cell cytotoxicity, or phagocytes. Activation of complement, classical pathway, and recognition of membrane receptors. F-type 3 mechanism, where we have cutaneous manifestations, vasculitis, glomerulonephritis, serositis, and arthritis. Here we have activation of complement, the classical pathway, and immunocomplexes deposition. And we have type 4, present maybe in CNS disorders, some rashes, vasculitic manifestations. Here we have a direct lysis of the target cell by means of T cells. We have production of cytokines with recruitment of inflammatory cells. This mechanism could explain the CNS involvement where antibodies do not arrive but T cells do. Also, some rashes might be explained by an involvement of T cells. Overall, all mechanisms but type 1 are involved in SLE manifestation pathogenesis. Additional info are: you obtain remission in 80% of patients. Of this, 50% will have another flare within 2 years. Kidney transplantation is not really effective. Transplanted patients commonly have a flare of the disease few years after transplantation, and we have destruction of the new kidney. Treatment tries to control the disease, but we cannot. Moreover, immunosuppression cannot be massive, otherwise we would have problems on the side of infections. Bone marrow transplantation could be an option in very